it's not just about medicalizing obesity, but also it's about understanding that we're not talking about cosmetics here. We're talking about health, well-being, quality of life.
Hi everyone, welcome to our latest Goggle Docs podcast. We've been considering a lot and taking more of a deep dive on obesity recently. And one of the areas that we wanted to focus on during this podcast are the costs of obesity and the complications of obesity beyond cardiovascular disease. When I think about people attending our practice, quite often they don't come with the complaints of being overweight. There'll be other things. And obesity and being overweight is just lurking in the background. So an example might be someone coming in with knee pain due to osteoarthritis. Sometimes it may be mental health problems. So a person feeling low in mood or having depression, anxiety, and almost a bit of a bi-directional relationship there with obesity and other chronic conditions as well. So although we focused a lot on the data that's come through scientifically on the cardiovascular risk and outcomes associated with obesity, I wanted to just focus today on everything else. Ahmed, how does that sit with you in terms of your clinical interaction with patients with obesity, and what are the non-cardiovascular complications that we need to be thinking about?
I think more and more these days we're starting to have a look at the bigger picture, so to speak, the multiple long-term conditions, comorbidities in people. We've done this traditionally for a long time in type 2 diabetes in the setting of cardiovascular disease and looking at weight as an add-on to that in terms of type 2 diabetes and weight management, type 2 diabetes and cardiovascular disease. In terms of, I guess, obesity itself, we perhaps don't look at some of the other systems as much. And you mentioned it quite clearly there, osteoarthritis, the impact of weight on the joints. And we see, if you look at some kind of a lot of the data coming out as well, I know we don't want to talk about that, but there is a lot of people say, a lot of kind of associations with joint pains and arthritis and type 2 diabetes and obesity as well. We've also got other things such as sleep apnea as well, obstructive sleep apnea. You can imagine with the pressures of that on the lungs as well, and oxygenation and hypoventilation. We've known about obesity hyperventilation syndrome for some time, but putting that in the perspective of the person in front of you saying, I'm not sleeping well or I'm tired all the time, thinking about what that means actually beyond just, okay, it's exercise, energy, etc., and sleep patterns. It's also about that weight management. Looking at, you touched upon it, you said mental health. There's varieties of mental health conditions associated with obesity. Looking even the longer term as well, we perhaps don't think about cancers as well, but oncology and a lot of the cancers attributable to obesity. Again, the impact on that's quite long term. We don't really think about that. But again, these are some of the things that we have to consider beyond just the traditional cardiovascular risk factors in the setting of obesity.
One thing I was just going to mention there as you were speaking, it for me falls into two categories. It's the preventable aspect. So managing weight in order to prevent these conditions that you've spoken about, but also when a person does present with those conditions, how weight management may actually benefit that person and their condition as well as their long-term risk. So there's both there to consider.
And this is bringing more and more into focus, something like the medicalization of obesity, but actually the impact it has. We're seeing more and more because we've got, it's been highlighted more and more by government, by options available in therapeutic management. So we're learning more and more. So things like CKD and obesity is starting to get more looked at as well. And gallbladder disease and other comorbidities as well, looking at in the setting of obesity. So the interlinking between lots of other pathologies and beyond our primary, secondary care, but also within specialties in secondary care, getting to understand obesity and the impact on respiratory medicine, for example, on nephrology you mentioned, and obesity, oncology, etc. So how that impacts. We're starting to learn a bit more about it as well.
So far-reaching impacts on the person living with the condition, but also on the health service as well. What does that look like, and how concerned should we be, Patrick?
I think we should be very concerned. I mean, we know that these obesity rates are rising, and the cost, if your BMI is above 35, I think there was a recent report, your healthcare costs are approaching twice that of someone with a normal BMI. So this is very expensive in terms of a state funded health service. And of course, if we just push back just a couple of years ago, we know the impacts of weight in terms of morbidity and mortality in COVID. To ventilate someone who's significantly overweight has its own challenges, and adverse liver conditions. So the costs, financial costs to the NHS are enormous.
So they're the financial costs, but I find obesity is one of those areas in medicine that is very closely aligned to social costs as well. And I think that's something that we really have to address also. Tell us more about that.
Yeah, I mean, it's certainly something close to my heart. I mean, I live in the northeast of England, as I said, primary care lead for diabetes in the northeast, North Cumbria. And we've got the highest rates of obesity. We've also got the highest rates of deprivation. We know the link between obesity and deprivation is enormous. And you've got whole cities, really, which are scavenged, really, by the impact of weight and the impact that has on people's ability to work. We've talked about chronic pain from not only osteoarthritis, but lower back pain as well. So, communities like Middlesbrough, Sunderland, Hartlepool, these are very close to where I live and work. So I think the cost, if we're serious about trying to tackle health inequity, we have got to tackle obesity. And it's not just a case of preventing it. We've got to deal with the people who've got the condition right now.
And I suppose now is the time, isn't it? We're at this juncture where we've got a lot of opportunities, not only from the medical management that is now available to us. We know about the surgical management options, also the lifestyle options there, but the importance of how society and government plays a role. You mentioned inequity there, and that's a real buzzword when it comes to obesity, isn't it? And I think this is an area that you've looked into recently, isn't it, Amar? Do you want to perhaps give us a little bit of a summary and perhaps a closing statement of why inequity is such an important aspect of obesity and overweight?
I think it's one of the key features, because if you look at the populations that are seeking support or intervention or seeing the healthcare professionals for any conditions, really, there's a link between level of deprivation, level of education, and health-seeking behaviors. So when you're dealing with a condition, any condition, you've got to really look at what are the drivers of that, what are the drivers of that health-seeking behavior, and how do you account for that in order to optimize care across the population. So we look at population-based care. It's easy just looking at silos of our specialties or our areas. But when you're looking at it from a national perspective or international perspective, you've got to see, well, how do you get that access? And really, that's down to awareness, education within these areas, but also making a system that makes it easier for people to access those elements, education, awareness, the interventions as well. And at the moment, in the UK specifically, there's still a massive difference between people who can access various treatment options. Part of it is, there's cultural elements to that. There's education elements mentioned, and there's access elements. So obesity is no different with that. And I think at the moment, a lot has been put on kind of this. We need to manage obesity, we need to talk about it, but nothing's structured in how it's going to be done. Even if you look at government kind of offering, driving money and support into obesity, what that means exactly is not really being quantified or even put into a kind of an algorithm or a chart or kind of a support document, really saying, well, this is what needs to be considered and done, what you can do at a local level, at a regional level, and at a bigger level as well, because it's not easy. And nobody really has probably put the blueprint down for that. And we kind of need people to do that, because otherwise it's just saying, here you go, do what you want. And that's what's happening. And it's not just about medicalizing obesity, but also about understanding that we're not talking about cosmetics here. We're talking about health, well-being, quality of life, and that's beyond just giving treatments. And it's also about making sure that access is there if you really want to make change.
Thanks, Omar. Thanks, Patrick, as well. I know this is an area very close to your heart, as you mentioned, deprivation, inequity, but also as clinicians interested in metabolic health, we're in such an opportunistic time right now as well. I think there's an intersection on many of these areas. But let's wrap up for today. Thank you for highlighting some of those key areas. I suppose ultimately as clinicians, our responsibilities to the person sitting in front of us, but I don't think we can keep our eyes closed and ignore the wider consequences of some of these long-term conditions. So with that, that's all from us today. If you enjoyed what you saw today, please do reach out and comment, follow us across our socials, and we'll hopefully see you again soon. Take care.